what I will do, just as a final sanity check, can people at home just confirm that I am audible now? Yes. Okay. Brilliant. Thank you. Yeah, you're good to go. Over to you.
Great. Thanks very much. Thanks for inviting me to speak, Sam. Very honoured to have the last spot. Hopefully, I'm not standing between you and a early drinks on a Friday evening. So hopefully, I have your attention. About an hour, I guess, because I started 10 minutes late. I'll end 10 minutes late. So introduce myself. So my name is Mark Horowitz. I'm a trainee psychiatrist and researcher. I run a clinic in the NHS that helps people to stop antidepressants. That's my major clinical work. I did so that you know that I'm one of you, I assume you're all masters and PhD students or postdocs from around these tracks. I've done my time in this parish. I did a PhD and a master's. I sat in these chairs 15 years ago. I did the Masters of Neuroscience, and then I doubled down the pain to do a PhD in cellular neurobiology of antidepressants and depression at the campus over there, the Centre for Cellular Basis of Behaviour. It still exists. So I was looking very much at what is the molecular basis of depression, how do antidepressants work. My work has somewhat strayed from that, as you might see. I'll go through and I'll give some time for questions. If you have questions, put them in the chat, I guess, online, or save them in your minds for the end if you're here. So I'm going to talk about, are we over-prescribing antidepressants, is kind of the unifying thesis of my talk. So I'm going to play a video that I hope will work. I'm going to show you a whole lot of, I'm going to bore you to death with graphs, of course, and statistics. So I thought I'd give a little bit of life to things with some human beings speaking before I inundate you with graphs. So these are three women who have been interviewed about their experience using antidepressants and the difficulty they had stopping them. And Sam will intervene if the technology doesn't work. So I guess for the rest of the lecture, what I want to do is sort of unpick how this reality fits in with what is in guidelines and what people are generally being told about antidepressants and why there's such a mismatch. Cool. So the context for this is a very big change in culture over the last few decades. And I think a big turning point in that was the Defeat Depression campaign that ran in the 1990s and 2000s in England. This was the first sort of anti-stigma campaign, you might call it, or public awareness campaign about mental health. And it was, this was the logo up in the top right. Probably most of you are too young to have remembered any of this. I wasn't in this country, I don't remember it either. There was two main messages in this. It was on billboards, it was movies, it was books. It said, feeling miserable, hopeless, despairing is a medical illness called major depressive disorder. And people should see their doctor about this as there are effective treatments. And it was presented to the public by the College of General Practice, the Royal College of Psychiatrists. They did some research. Why wasn't it being taken up as much as they wanted? And there was two major blocks. Number one, the public felt that being miserable, hopeless, despairing is caused by life problems like divorce, job loss, financial problems, and illness, not a medical illness called depression. And they were afraid that any medication that affects mood will be dependence forming and will be hard to stop. And so they set about trying to knock over those two reservations. And they said things like, this is where you probably heard these things hundreds of times. This is where they came up with depression is a medical illness like anything else, like diabetes, like heart disease, to try to say it's not about life. Yes, life might bring it out, but it's fundamentally a biological problem like any other medical problem. And they repeated again and again and again, antidepressants are not dependence forming and will be no trouble to stop. Those are quotes from this campaign. The campaign was basically successful. It ran for 15 years. Rates of antidepressant prescribing went from extremely rare, 3 out of 100, to very common, 1 in 6. And although it was fronted by the Royal College of Psychiatrists and General Practitioners, it was funded by the major pharmaceutical companies in the country. The colleges thought, well, their aims dovetail, so there's no harm in taking money. Of course, it's gone well beyond that now. I'm sure you're all young people, you know how to use the TikTok, and people are talking about their mental illnesses without need to be paid by drug companies. It's become a ADHD, of course, and autism are now the kind of the diagnoses that are most talked about. So just sort of taking a step back and giving you a bit of a cultural history. I'll come back to antidepressant biology at the end. Where did major depressive disorder come from? So this is really, there was, I think, a very big turning point in the history of civilization in 1980, where the DSM-III was published. So the DSM-III, the Bible of psychiatry, the diagnostic manual. The previous versions, DSM-I and DSM-II, they had mental health conditions categorized by different reactions. A chapter on anxious reactions, depressive reactions, psychotic reactions, with the understanding that reactions meant to events in people's lives. People had certain patterns of response. Most people become depressed or anxious, some people become psychotic, etc. In the 1970s, a bit like today, maybe psychiatry is on the up these days. Psychiatry was under attack as not a real medical specialty, and therapists were saying, first of all, psychoanalysis was not seen as solid science, and therapists were saying, one, we're better at therapy than you guys are, and two, we're cheaper. And so psychiatry is on the back foot, and their response was to re-establish their credibility as a medical discipline, and so they shifted to a disease model. So rather than talking about depressive reactions, they talked about major depressive disorder, capital letters. Rather than about anxious reactions, they talked about generalized anxiety disorder. People think when they hear those words, there must be research finding chemical imbalances, neuroimaging, prognosis. There must have been some sort of research to change things, but that's not the case. It was a decision by the committee, mostly middle-aged white men in Northeast America in the 1970s, who published a book in 1980, and they, do I have it here? So essentially it was based on consensus. There was a book written about this where the members of the committee were interviewed. How did you come up with these diseases? And they said various things. We had very little in the way of data. We thrashed things out. We used a vote. So, for example, they decided that 6 symptoms for a disease would be too many people to hold in their heads. 4 seemed too few. So they chose 5 symptoms. So to diagnose major depressive disorder, you need 5 symptoms out of 9 for more than 2 weeks. Other quotes here. So here's one of the members of the committee saying, it wasn't scientific, it resembled a group of friends trying to decide where they want to go for dinner. One says, I like Chinese food, another says, I'm more in the mood for Indian, and they would compromise on Italian. This is a professor of anthropology interviewing the members of this committee. Another one said, we can't include that behavior as a symptom because I do that. This is the member of the committee saying, if I do that, it must be normal, it can't be pathological. So of course the behaviors and predilections and biases of the members, of course, affected what was put on it or not. There's a couple of other things I didn't put in here. There was going to be a condition called masochistic personality disorder, which was typified by women that attracted abuse from their partners. It was struck out at the last moment by a group of psychologists who said this condition will be used in courts to get men off abuse because the defense will say, well, it's the woman's mental illness that has pulled out this abuse from men. So you can just see how political and how subjective these diagnoses are. The other famous one, of course, is that homosexuality was a mental illness until it was voted out because of protests from gay members of the Psychiatric Association. So just to sort of make it clear how culturally determined these diagnoses are rather than being defined by neuroimaging chemistry. So skipping around a bit, so I'm giving you a bit of a grab bag of different ideas in this area. What causes depression? So for many years, the public and doctors have been told that antidepressants work by rectifying an underlying chemical imbalance. You've probably heard that. There are surveys of the public where 85% to 90% of people say that depression is caused by a chemical imbalance. Sometimes it's translated by doctors to patients that antidepressants for depression is like insulin for diabetes. Now, the history of this is, in the 1960s, this is a legitimate scientific hypothesis, came up by an American psychiatrist called Schildkraut, and it's been researched for 6 decades. People have looked in cerebral spinal fluid, they've looked in urine, they've looked in post-mortem analyses of people with depression and healthy volunteers who have died, they've looked in their brains, they've done imaging, they've done every single way you can get at serotonin. And we summarised this work in a paper we published 3 years ago now, and we found that if you add up all the different studies, some find that serotonin is increased in depression, some find it's decreased, some find it's the same. If you average them all up, there's essentially no average difference. Let me just see what the next slide is. So we published that. I'll show you the responses, so I think it's very illustrative to this paper. It became it was on the front page of most papers in the country that day that it was published 3 years ago, because everyone was very surprised. One of the journalists that my professor spoke to said, "Holy cow! I thought this was like gravity, that depression is caused by low serotonin." So there was huge kind of surprise from the public and from journalists. The response from the psychiatric institutions was the opposite. They said, "We never believed this. No one. This was sort of meant as a metaphor." So the Royal College of Psychiatrists said the old idea that antidepressants correct a chemical imbalance in the brain is an oversimplification. We do not support this view. They've removed this sort of language from their leaflets on depression. In America, a prominent US psychiatry leader referred to the chemical imbalance notion as a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists. And the American Psychiatric Association, the equivalent of the Royal College of Psychiatrists in America, said additional experience has not confirmed the monoamine depletion hypothesis, monoamines being the group of neurotransmitters which include serotonin. After that was published, people asked a lot, well, what causes depression? If it's not serotonin, is it noradrenaline? Is it inflammation? Is it stress hormones? Is it genetics? And I remember being very puzzled by this when I did my PhD. I spent years and years looking at stress hormones and inflammation, neurogenesis. I wasted all my evenings and weekends for years in the tissue culture hood over there. No resentment, no trauma. But I feel like my grandmother would have given a very clear answer to the question, what causes depression? And she would have said, when life's awful, people are depressed. And maybe your grandmothers would say the same thing. And that's what the best research shows.
When it comes to this,
Yeah.
I think it's fascinating because I'm fascinated to see why, when it comes to mental health across the world, what's actually going on. And I'm looking at communities that they talk about mental health, talk about medication, but I'm like, what's the root of what's going on? And I actually think, as somebody has told me once, and I actually think it's a good answer, as time has gone on, stressful, the economy, the culture, the pressure, and you just don't have time, one, for self-care, two, for anything anymore. Back 10, 20 years ago, you might have had more money, less stress, more time. This will impacts. So
Sure.
I find this fascinating.
Preach, sister. That's what the evidence shows. That's what the evidence shows. So this is a study. This is the biggest study that's been done that asked people. It's very simple. In the last year, how many of the following stressful life events have you experienced? Stressful life event is divorce, job loss, diagnosed with a major medical illness, move cities. It doesn't even include lots of small things like moving house or environment. Exactly, lots of things that are not registered on this. Racism, time pressure. So it's got to be big ticket items. Divorce, death. It's got to be able to tick a box. And that's on the x-axis. If you have no issues in your life in that year, it's called. He calls it contextual threat. If you have more than 10, it's severe, and in between is minor, low, moderate, high, moderate. On the y-axis is your risk of being depressed in the 2 months after that 12-month period, in terms of hazard ratios. And what it shows is, if nothing goes wrong in your life, basically very few people are depressed. If everything goes wrong in your life, lots and lots of people are depressed. And I would say, in medicine, I've never seen a gradient this steep, except when it comes to smoking and lung cancer. This is I don't have all the data here. If you look at inflammation, stress hormones, neurogenesis, sometimes we find a 5% difference, sometimes you find 5% less. This is a 30-fold increase from low to high. This is an incredibly steep relationship. And personality plays a role. So all the different coloured lines are people's personalities. Neuroticism basically just means how sensitive you are to stress. Yes?
Shouldn't people have evolved over time? I'm thinking back in the day, there wasn't as much and they could cope with what was going on, and things have changed, but I feel like
Evolution doesn't happen that quickly. We don't know.
there's no coping, and that's why, you're seeing this.
So low neurotic people are people that are not very sensitive to stress, and that's someone like Obama, that's the green line, and someone who is very sensitive to stress. I think Woody Allen's been cancelled now, but someone like maybe Mr. Bean is up there. And in that there's a bit of genetics. Of course, your personality is affected by your upbringing, by your family, and by genetics. So it's not completely about life, but a huge proportion of it is about what happens to you in life. The upper limit for how much genetics is involved in depression is 37%. There's a lot of criticism of that amount, but compared to something like height or eye color, which is 90%, 37% is actually quite low in the scheme of things. This also speaks to, people always talk about uncaused depression. I remember learning about that in medical school and psychiatry training. There are people out there whose lives are fantastic and they're still depressed. I've never seen someone like that in my clinical practice, and it's not found in research. When there's no stresses, people are not depressed. So this idea that depression comes from the heavens or from genes or things going wrong is not found in research in general. Not nobody, but it's 99.9% of it comes from what's going on. Another point to sort of talk about depression and how normal it is. So this is wrong. It should be 45 years. So there's a great study done in Dunedin. You know those movies 7 Up, where they follow people every 7 years and they make a little documentary? Basically, they did the science version of this, much less exciting, where they gave people the diagnostic interviews for mental illness every few years. They basically went to a city, town in New Zealand called Dunedin, and they recruited 1,000 people born in 1979, 1980, I think. They followed them up for 45 years and gave them these tests every 5 years. By the age of 45, guess what proportion had met criteria for mental illness at any point in their lives, and how much of it was, so that should be major depressive disorder, MDD, or generalized anxiety disorder, GAD. Guesses? 90, very good guess. It's 86%. So you should get the apple for that. And most of that is anxiety and depression. So 70% of all people, 70% of all of us meet criteria for anxiety or depression by the age of 45. In other words, you're an exception if you don't. I always think, I've got a friend of mine who's incredibly optimistic, he's wealthy, he's handsome, people like him, never seen him depressed. I hate his guts quietly. But everybody else I know has had a period when things have gone wrong in their lives, but they've been anxious or depressed. So it's very normal. And the other thing I'd say here is, how could it possibly be that 70% of us have something wrong with our serotonin or our brains? It would be very abnormal.
How have they normalized it like this? This is alarming. I'll be blunt. You wonder why people are just saying, well, might as well just take a tablet, and not like that, but I'm seeing it because instead of having coping mechanisms and having talks like this, no, you know what, there's the statistic, that's it, might as well.
So one of the reasons for this has been the expansion of the DSM over time. So there used to be 12 chapters and there was 117 diagnoses, and now there's 450 diagnoses. So there's been expansion of the diagnoses, there's been lowering of the thresholds, and that means more and more people meet criteria for a mental health condition. Keep going. So how do antidepressants work? So if there's not, I didn't go into it very much, so I just so I should have gone into more detail. In this study that we talked about, the low serotonin study, we went and we looked at, all the studies that looked at cerebral spinal fluid, brain, postmortems, genetic studies, etc., etc. I haven't put the details here, you can look at the paper, but we found there was no effect. And I should have said other responses around the world were psychiatrists saying, yawn, we already knew this was not news to us. So that was one of the major responses. So if depression is not caused by low serotonin and antidepressants can't fix it by increasing serotonin, what are they doing? And in my misspent youth, doing my PhD, I looked at other reasons for why antidepressants might be working. And my PhD was a set of null results and I thought it meant that I was a terrible scientist, which I might be. But it turns out that everyone has null results. So other theories about neurogenesis, that depression causes the reduction in the growth of new neurons, antidepressants might fix that. I spent 3 years doing that. That depression might cause increased inflammation, antidepressants might reduce that. I spent 3.5 years looking at that. To summarize, most of these ideas come from animal studies. They haven't been shown in humans. There's a meta-analysis done by Kennis in molecular psychiatry where they looked at all of the predicted variables. So is interleukin-6, TNF-alpha, IL-2, cortisol, GR function, all the different things that you would predict BDNF, are they found to be different in depressed versus healthy volunteers? And they found null effects across the board. So none of these theories are supported on meta-analysis of these studies. I just want to point out probably the most popular theory around is neurogenesis, that antidepressants might improve depression by growing new brain cells. So first of all, that comes from animal studies. And two, it ignores an idea that I was only told this, so I did 3.5 years counting cells, neurogenesis under a microscope. It was only after I finished my PhD that someone said to me, did you ever think that actually neurogenesis could be caused by damage to the brain, that blunt trauma and stroke and chemicals that damage the brain cause neurogenesis in the same way as cutting your skin causes the growth of new skin cells? It's not a sign. The growth of the cells is a good sign. It's a sign of repair. It doesn't mean the thing that did it is good for the brain. And so for the first time, I thought, it could be, if antidepressants do increase neurogenesis in the brain, it might be a sign that they're toxic. And you've got to think, is it more likely that Eli Lilly and AstraZeneca have invented miracle grow for the brain, or that these industrial chemicals might be noxious in some way for the brain? So I just, because you see all over the place, someone will say, we have a new treatment. It increases neurogenesis, increases new brain cells. It must be good for you. They say for ketamine, they say it for electroconvulsive therapy. And I always hear, when I hear that, I think, is that a good thing? Another way of looking at it is, is more bricks in a house a good thing? If you have more bricks in your house that builds a loft and it increases your sale price, that's great. But if the bricks go in your living room and you can't see the TV, it's not so great. So I just want to sensitize you every time you hear new brain cells, just be a bit skeptical about what that might signify. I'll try to get through my lecture, I'll run out of time and take your comments at the end. So how else might antidepressants work? There's a very obvious explanation that people don't like to talk about because it doesn't sound very high tech. And in fact, it sounds probably a little bit concerning. And that is, in surveys of people on antidepressants, between 1/2 and 3/4 of them report emotional blunting or numbing. What they're saying is, the range of my emotions from very high to very low, negative to positive, is squished into the middle. So that can be useful. If you have panic or anxiety or depression, it's 10 out of 10. Turning the volume down to a 3 could be a great relief. But it's not the same as fixing an underlying chemical imbalance that causes the symptoms. It just so happens that antidepressants also cause genital numbing. They cause lack of sexual desire, issues with ejaculation and orgasm in both sexes. And on studies, those are correlated. So emotional numbing and sexual numbing are correlated in the same person. And because I spend a lot of time getting people to take small doses of these drugs, I know that if you crush up these tablets and mix them with water and swish them around your mouth, it will actually numb your mouth. So there are anesthetic properties to these drugs. For a while, people said, well, maybe it's the depression causing the numbing. And maybe that's true. Maybe depression can cause a bit of numbing. But they've also done a study a couple of years ago at Cambridge where they gave a common antidepressant for 3 weeks to healthy volunteers and showed the exact same effect of emotional numbing. And so I guess there's a flip side to that. So the number one reason people come to my clinic in North London to come off their antidepressants is because of this numbing effect. It might have been useful in the short term, but later down the track they say, I don't know if I love my partner anymore. I used to be interested in music and art, now I don't care. Or as the woman said, probably the most gut-punching sentence in that video was, I'm not sure if I'd want to with my children properly while they were growing up. So we'll come back to it. I do think that informed consent for antidepressants involves saying that this is the most likely way that they work. You might want to use them, but I think implicit in this explanation is an idea. You may not want to be on them long term because of consequences if you use them. This was a qualitative study. People were interviewed. How does being on antidepressants make you feel? This is some lethargy, sleepy all the time, difficulty focusing, fogginess, inability to care about things, etc., etc. So I want to bring out a more general point here. We're going to talk about antidepressants in more detail. I think this, if you forget everything else I've said, I think this is an important slide. There's two different ways, because this is about psychiatric drugs in general. I remember when I was looking at a microscope for several years in my PhD, I was obsessed with, does this antidepressant affect IL-6? Does it affect IL-2? What dose affects neurogenesis? And I sort of didn't think about what is the effect of these drugs on people. So I found this theory to be very sobering. There's two ways of thinking about how do drugs work. On the left-hand side is something called the disease-centered model. And this comes from general medicine, where I think it makes good sense. Why does an antibiotic work? You've got a cough, you've got a fever, you feel terrible. You take an antibiotic and it kills the bug that's causing the pneumonia, and so you feel better. In other words, the drug is correcting something that is abnormal in your body that makes you feel better. So another example would be insulin for diabetes. If you've got diabetes, you don't have enough insulin. You take insulin, it fixes the underlying problem. And psychiatric drugs are often presented as working in that way. That's where this low serotonin comes in. You've got low serotonin, or the drug fixes it just the same way insulin affects diabetes. But that's not true. If there isn't low serotonin and drugs are not doing that, what could they be doing? I've given you an example with antidepressants that they could be numbing. But a more general kind of extrapolation is that all psychiatric drugs, benzodiazepines like Valium or Xanax, antipsychotics, mood stabilizers, you've heard of examples of them, lithium, lamotrigine, etc., that they work not by fixing an underlying problem, but by superimposing a feeling on what's already there. So an example would be, if you've got social anxiety and you drink alcohol, you feel less anxious and less inhibited at a party. No one thinks that alcohol has reversed the underlying cause of social anxiety, or that social anxiety is caused by an alcohol deficiency. Everyone understands that your anxiety has had alcohol's effects superimposed on top of it, and alcohol is disinhibiting, it makes you less anxious. And so some people suggest, and I think it makes a lot of sense, that psychiatric drugs act more like that than like antibiotics. So you give a drug like Valium that relaxes you, and you feel less anxious because it's had that effect, not because it's fixed an underlying problem. And the same for antipsychotics, which are very tranquilizing drugs. It tells you a few things about the drugs. So you can see that it sort of sounds like a language game. It's still the drugs kind of helping you, but it puts into your mind, what's that thing that psychologists will talk about? Heuristics, guessing about what's going to happen in the future. With alcohol, if you drink alcohol for anxiety, that there's going to be consequences. You're going to get tolerance to the drug. It'll wear off over time. When you try to stop the drug, if you use it every day, you'll get withdrawal effects. And the drug is likely to have lots of toxic effects in the long run. So if someone said to you, alcohol is very good for anxiety, but it's likely to cause more harm than benefit in the long term, you sort of nod along. That makes sense. Whereas if I said to you, I don't know a huge amount about insulin, I'm not an endocrinologist, but when I hear insulin normalizes a lack of insulin in diabetes, I think it's probably going to be safe in the long term. You're missing it, it's a normal hormone, you're giving it back, it's going to be safe. And I don't think there's any evidence otherwise. So where you stick antidepressants or other psychiatric drugs in these categories gives you different predictions. And I'm going to tell you that a lot of what we know about antidepressants, it makes it fit into the second category. That there is tolerance effects, there are withdrawal effects, there are toxic effects from long-term use, and that for a lot of people, the negative effects outweigh the positive effects in the same way, while they can be useful in the short term, in the same way that alcohol can be. So those are called the disease-centered model and the drug-centered model. I'm going to very quickly talk about what is the evidence for antidepressants being effective or not. And then I'm going to come back to withdrawal, going around the houses here. So so what is better? How do you define how much better is better? This is basically bit confusing. This is basically a study in which they asked doctors how much improvement. So the reason why I talk about this is, have you heard about the Hamilton Depression Scale? It's a 52-point scale. You ask people, do you sleep okay? Do you feel depressed? Do you want to kill yourself? How are you eating? And it's scored out of 52. And everyone sort of thinks, what does a score mean? Is like, if I give you a drug that makes you 10 points better, is that good? Or is it 2 points? Or is it 1 point? So they try to turn this into human language. And they ask doctors, how much improvement on the Hamilton Depression Scale do you need to see before a doctor can say, look, this person seems a bit better, they seem a lot better, or they seem amazing? And the answer was a 3-point improvement. Doctors thought there was no change. At 8-point improvement, they started to say this person's minimally better. 14 points, they said much improved. 20 points, very much improved. So what do antidepressants do? So basically, to summarize 1,000 studies on antidepressants improve depression scores on the Hamilton Depression Scale by 2 points compared to placebo sugar tablets. This is a picture, not of the 1,000 studies, this is 11 studies. I show this because it shows it nicely week by week, although this study shows a bit more than the average, 2.7 points. What you can see is the placebo effect is very large, and the antidepressant effect is a bit more on top of it. Inside the placebo effect is people get better over time. If you get divorced, lose your job, things will be better 6 weeks later. When you're at your worst point in life, 6 weeks later, you're a bit better on average. It's called regression to the mean. On the day that you're most nauseous, on average, 6 weeks later, you're less nauseous. And there's the placebo effect, which basically means placebo means I hope in Latin. So it means people have hope that they'll get better. And so the antidepressant effect is very minor compared to that. And you can see it's much less than what people think of as no change, and much, much less than minimally improved. So people argue that while antidepressants beat placebo to a statistically significant difference, it's not clinically important. A bit like if you said, I've got a new weight loss pill, but it'll only make you lose 50 grams of weight. It might be statistically better than placebo, but no one's going to take a tablet with side effects just for a 50-gram weight loss. Similar things operate for antidepressants. One study has tried to isolate the placebo effect. And it did it in a very clever way. Basically, it involved lying to patients. I don't know if it would be legal to do today. They gave everybody in a study an antidepressant, and half of them they said to them, we've given you an antidepressant, and half of them they lied to as we've given you a placebo with side effects. And so the only difference was the thoughts in those people's heads. One of them, they all got antidepressants. One of them thought I've been given an antidepressant. One of them thought I haven't been given an antidepressant. And the difference between those two groups, told it was an active placebo, they improved by 4.6 points. Told it was an antidepressant, they improved by 9.7 points. In other words, the placebo effect that they've isolated here is bigger than the difference between antidepressants and placebo. So some people argue that the entire difference in these studies is due to people knowing they're on the drugs, and that gives them a bit of hope and expectation. So some people say the entire thing is they call it a amplified placebo effect. Just to add to it, there's a rule to get a drug approved to be used in America or the UK. You have to show that it beats placebo in 2 studies. But the trick is you can do as many studies as you like. So you could do 11 studies, and if you show that 2 are positive, you get a green light from the FDA or the MHRA. And so one very industrious researcher 15 years ago wanted to go look at what's the real story. Yeah.
Do you have to report all studies? Yeah.
I think it's changed these days, but in the bad old days, no, you didn't. You had to submit more to the FDA than you had to publish. But now they're trying to catch people like this by having registered reports, the sort of thing, open science thing that Sam's but yeah, in the bad old days it was much more lax. So this is a great 2 slides just to represent a very big study in the New England Journal of Medicine. If you look at published versions of antidepressant trials, 48 are positive. Positive means the antidepressant beats placebo, and only 3 are negative. That means there's no difference. This researcher said to the FDA, I want to see all the trials, published, unpublished, that you guys have had submitted to you. So it's not even actually all the trials, but it's all the trials that the FDA had submitted. And what he found was the graph became like this. In other words, there was about 20 studies that had never been published that were all negative. And if you look up the top, 10 studies that were there that were positive were actually spun in the journal articles from being negative to being positive. So 10 of them, the data underlying them did not show that the antidepressant beat placebo. So if you look at it, it's a coin toss now. 38 for, 36 against. The last thing is that antidepressant trials go for 8 weeks. So all the trials I've shown you before all go for 8 weeks. Now, in the UK, half of people who are on them, so there's 9 million people on antidepressants in this country, by the way, this isn't some minor issue. 4 million are on them for more than 2 years, 2 million are on them for more than 5 years. In America, there's 25 million people on the drugs for more than 5 years. Now, any drug you take, you get tolerant to over time. Alcohol, opioids, Valium, anything that you take runs off over time. And so an 8-week trial tells you very little about what's going on years down the track. If you gave people cocaine, heroin, alcohol for 8 weeks, they'd probably feel a bit better. But we all know that down the track, things probably change. These days, drug companies try to do 4-week studies. Because the sort of the smaller time, the more benefit they can show. So you might have heard ketamine is all in the news. It's based on 4-week studies. Some of them are based on 3-day studies.
What's on the source for the treatment effects were only measured for 8 weeks? Because I've seen a lot of studies that measured for more than 8 weeks and for the maintenance treatment and everything. So
So this comes from the biggest meta-analysis of antidepressants by.
If you just slightly repeat the question, so
sorry,
for the online audience.
So the question was, where's the reference for these 8-week studies? Because a member of the audience is saying that she's seen long-term studies. I think that you're talking about the discontinuation studies, maintenance versus discontinuation, because the efficacy studies, there's a paper, there's a couple of papers. I'm referring to the Cipriani meta-analysis in the Lancet, which looked at 522 studies, and it looked at the 8-week time points. So there are 2 existing studies that go for longer than 6 months, but 99% of all antidepressant efficacy studies go for 8 weeks or less. Andrea Cipriani, 2018 in the Lancet, he did a meta-analysis, systematic review of all antidepressant trials. There's a more recent study from Vinay Prasad in JAMA Internal Medicine, where he looked at the median time for antidepressant trials is 8 weeks. Cool. Another issue that people bring up is about the severity of depression. People say antidepressants are more effective for severe depression. It's not true. This is a study, is a meta-analysis done by researchers who work closely with drug companies. Sorry, I should say that the reference I just gave to the young lady at the back was also done by a group that is associated with drug companies as well. This study looked at what is the effect of placebo, what is the effect of antidepressant based on their baseline depression score. So again, the Hamilton Depression Scale is called different things, but this is another acronym for Hamilton Depression Score. A score of 10 on the x-axis means very mild depression, and a score of 35 is very, very serious depression. And the blue line is the meta-analytic summary of the placebo effect, and the red line is the active drug. And you can see the difference at mild depression is very, very tiny. It was 1.1 points, way less than that 8-point minimally clinically important difference. But even for very severe depression, the difference only gets 2.2 points. So it's bigger, but it's still below what counts as a clinically important difference. And some people have argued the reason why it's a bit bigger is just because of percentages. The 10% change of a higher score is going to be a bit bigger. So it's not true to say, although a lot of guidelines recommend this, that antidepressants are more effective for more severe depression. There's still very minor effects on average the whole way through the depression severity scale. Adverse effects I'll talk about very quickly. Some people are told adverse effects only are there for the first few weeks and they go away. Number one, if they do go away, that's a sign of tolerance to a drug, just what I've been talking about, that sets you up for withdrawal later on. But number two, they do persist for lots of people. So what can I put out? A few things. Gut problems are very common. Sleep disturbances, lethargy, drowsiness. Sexual dysfunction occurs, depending on which antidepressant you're on, for between 50 and 80% of people. It includes desire, sensitivity, orgasm, arousal. There's a new condition that's been recognized called post-SSRI sexual dysfunction, which is a condition where people who stop an antidepressant have persisting sexual dysfunction that goes on after stopping. It can include genital anesthesia, which means a lack of sensation completely in the genitals. There are different studies that try to estimate its prevalence, some as low as 1 in 200, some as high as 1 in 7. Warnings have been put out in Australia by the equivalent of the MHRA, and it's now on the drug labels. So it's something that's a bit concerning because everyone was told for a long time, if you have sexual problems, you can just stop the drug, it'll go away. And now we're not so sure about that. Emotional numbing I've mentioned, and it can cause anxiety, agitation, and akathisia, this sort of restlessness, especially in young people. This is a study done in people who've been on drugs more than a year on the right-hand side, and it just shows how common, even after a year of use, these symptoms are. See a list of them there. There are rare but serious side effects. So, for example, in pregnant women, being on an antidepressant in the first trimester of pregnancy increases your rates of fetal abnormalities such as cardiac malformations by 2.5 to 3-fold from a very low rate. So 1 in 1,000 is the normal rate for a normal woman, and it goes to 2.5 to 3 out of 1,000. So the absolute increase is small, but the relative increase is quite large. As you get older, antidepressants increase your risk of bleeding, fractures, falls, and various other physical health conditions, partially because they affect platelet clotting. So serotonin is very important in platelet communication. That's why you get a whole lot of issues related to bleeding. And the falls are probably because they make you a bit dizzier and a bit more unstable on your feet. This is a survey. This is a self-selected survey of, I think this is more than 1,000 people, long-term users, who were asked, what side effects do you have? And this is what they said: emotionally numbed, feeling foggy and detached, but not myself, sexual difficulties, drowsiness, withdrawal effects, addiction. I'll come back to people are saying they're addicted because they can't stop, not because they kind of need more and more and more. We'll come back to that when we talk about withdrawal for a second. So I'm going to talk for a few minutes about where I sort of began with the video. How hard or easy are antidepressants to stop? So for a long time, the NICE guidelines, that's the UK government. Sorry. Sure, that's a fair point. In this survey, people were asked, what has changed since you started an antidepressant? But that's right, it's a criticism of these studies. How can you tell the difference between depression and the antidepressants? I guess the argument would be, the simplest argument would be, if the antidepressants worked, why would they feel like this? This is one thing. Yes.
So could you not say that if there's been a baseline change? So if there's no baseline change, then they're not working, and so it kind of doesn't really matter. And if the baseline has gone up, that's a massive red flag. It's being caused by.
Exactly. That's one of the arguments. You're right. It's not a controlled trial, so you can't, compare it to placebo. Exactly. The simple one just said in front of you. The simple answer is, well, if the drugs are working, shouldn't be this. This shouldn't be 3/4 of people like this. But you're right. You can't use these studies to determine the incidence of these things for the reasons you said. So the last 25 years, up until a few years ago, the NICE guidelines on antidepressants said that withdrawal effects from antidepressants were brief and mild, lasting a week or two. See what I'm going to say here. Oh yeah, I'll just go through. The reason why the guidelines said this is because it's very similar to what I've been talking about for the effectiveness studies. What drug companies did was they gave people antidepressants for 8 to 12 weeks in the same trials that I've talked about, where they showed the effectiveness. And after that, they stopped the drugs. And in these studies, they showed that most people had brief and mild symptoms. It's true. Some people didn't. A few people already had severe symptoms after 8 weeks, but it's true that most people had brief and mild symptoms. They published 20 such papers. And when the NICE guidelines did their literature search, they found 20 papers saying brief and mild withdrawal symptoms. That's what went into the guidelines. Of course, the trick is that I said 4 million people in England are on the drugs for more than 2 years, 2 million people are on them for more than 5 years. The longer you're on a drug, the more severe the withdrawal effects. Like if you drink caffeine for a few days, no big deal to stop it. 10 years, much harder. And so one of the reasons why the women at the beginning of this video kept on saying, I went to my doctor, they said, this doesn't happen, get off this computer groups, what are you talking about, is because they're looking at the NICE guidelines that say brief and mild. And the women are coming in saying severe, long lasting. To me, it's a little bit similar to a car company crashing its car into a wall at 5 kilometers an hour in a safety test and saying it's safe on impact, and ignoring the fact that people are driving around at 60 kilometers an hour on the roads. there's been a lot of research in the last few years, and as a consequence, the Royal College of Psychiatrists and NICE have updated its guidance to warn people that there are severe and long-lasting withdrawal symptoms on and after stopping antidepressants. And NICE has also made similar updates. We did a survey. I probably should have started the lecture by saying I used antidepressants for 20 years. It would have made me a more sympathetic lecturer. But anyway, in a survey we conducted in IAPT, if you guys know what IAPT is, it's now called Talking Therapies. We found that 40% of patients who are on antidepressants in IAPT were unable to stop an antidepressant despite trying 1 and sometimes more than 8 times, which means there's a lot of people in England who might be trapped on the drugs for this reason.
I read, but one of the reasons why people go on specifically in that environment is that the waiting list for the IAP service is so long, specifically 52 to 53 weeks at the moment.
Is it really? Right.
For one-to-one. So they either, what happens is they get, best practice is to be put on antidepressants, obviously in a close relationship with your GP, but then also be put in group or online CBT until something comes along.
Right.
So it's kind of, it's do something, then do nothing.
Yeah, I thought the waiting list was more like 12 weeks, but maybe, I don't know. So that's 52 weeks is horrifying.
I guess I should caveat that with in the most severe cases.
Right. All right. Yes. I mean, that's, there's a whole lot of things that come into that. People think that antidepressants are much cheaper than therapy. So in England every year, 1 million people get talking therapies, but 8 million people get antidepressants. If you ask people their preference, it's the reverse. 4/5 of people would like therapy, 20% of people would like antidepressants. Therapy costs more money. Antidepressants these days are off patent. They cost about £3 a month, or even less. Therapy obviously costs more. One of the, I think one of the issues with that is that the long-term cost of antidepressants are not priced in. So you're sort of beginning 3 women who all lost their jobs, who all dropped their social, duties because they were so sick for years in withdrawal. That's not priced into the £3 that a tablet costs. When you stop CBT, you don't get years of withdrawal from it, unless it's a very good therapist. So I think there's lots of short-sightedness. But you're right. There's lots of pressures in the system that contribute to this sort of thing. I'll just finish it off a few minutes. One of the consequences of this, you sort of heard these women. Oh, so you go.
I want to ask you about addiction and
Withdrawal. Okay, that's a great question. Yeah.
Sometimes there are people who cease drinking alcohol. They have severe withdrawal symptoms as well, but you can tell them they are addicted to alcohol, but you can't tell the antidepressant patients addicted to antidepressants. So how can you distinguish these two concepts? And because there are some people that stop drinking alcohol can stop directly, like they never drink again, but there are still some withdrawal symptoms. Okay.
So I'll just show you. So it's my next slide here. I'll talk about it now. I'll come back to that one. So withdrawal does not imply addiction. So this is a point I want to get in people's minds. So there's 2 concepts. There's physical dependence and there's addiction. So physical dependence is, so I'll give you an example. All of you are dependent on caffeine, I assume. If you're master's students, PhD students in the modern world, I assume that none of you are injecting caffeine or stealing from your neighbours to get caffeine, because none of you have an addiction issue. You're all physically dependent. If you stop it, you'll get a withdrawal syndrome. Not the most unpleasant withdrawal syndrome, but you'll get one. So physical dependence arises from repeated use of a drug that affects the brain, like caffeine, alcohol, benzodiazepines, opioids, and antidepressants. Addiction is an additional thing, psychological dependence, which is defined as compulsion, craving, obsession with the drug, which can happen for heroin, opioids, and some benzodiazepines. So the difference, so you don't need to be addicted to something to get withdrawal effects. You just need to be physically dependent on it. And that's what's true for antidepressants. The flip side of that is tolerance effects. That any drug you get withdrawal from, you must be tolerant to. The more tolerant you are, the more you get withdrawal. So good question, thank you. I'll just quickly say, the women at the beginning talked about going to these groups. Doctors saying, get off these groups. What are these groups? These groups are social media groups on Facebook, different peer support sites, where patients go after they've been told by their doctor, this can't be anything to do with the drugs. And the sort of story you get on these sites is, I was told to stop taking my antidepressant over a few weeks. I had the most horrendous time I've ever had in my entire life. Maybe I ended up in hospital. I had to go back on the drugs. Doctor said, brief and mild is in the textbooks, so it can't be to do with your drugs. It must be your terrible mental illness. Okay, I know you went on the drugs because of work stress, but somehow you developed this incredible suicidal madness. You must need the drugs. Don't stop them ever again. And the patients go, what the hell? I've had, I was dizzy. I had headaches. I had brain zaps. I've had panic attacks for the first time in my life. I don't think this is me. I went on this because I didn't like my PhD. Here I am, in hospital. And they go on these websites. They found people that have very similar experiences to them. And they get told, won't label this, they come off your drug much more slowly. Come off at 10% of your last dose per month. And it takes them months and years to come off rather than weeks. I'll scoot through here. Withdrawal effects affect multiple systems in the brain. That's why you can get psychological and physical symptoms. Here's a whole list of them. There's research showing there's an increase in suicide attempts after stopping the drugs, even in people that were not suicidal before they started them. In other words, these can be severe. This is not just, I think headache and dizziness have sort of made it to the news, but I think how severe these symptoms can be has not. Akathisia was mentioned by some of the women. It's a Greek word for meaning can't keep still. These are the 6 people that I see. They're agitated. They are pacing often. There's a high risk of suicide because people sort of in this state do not get any break for weeks and weeks after. To me, it's sort of like the nervous system has been knocked around in this awful way. I won't go into this too much. Basically, withdrawal effects can last a lot longer than a week or two because it's the time taken for your brain to recover from the drug's effect on the brain that explains how long they last for. So some doctors think it's how long it takes the drug to leave your system, but it's how long the drug leaves a residue on your system. So I'll give you an example. You go to a loud concert, your eardrums become less sensitive to sound. And when you walk out into the quiet street, your friends' voices sound muffled for a minute or two. It's actually a sound withdrawal syndrome. Although it takes only a second for the sound to dissipate when you shut the door to the concert, it takes your eardrum a minute or two to relax. And so it's the time taken for your brain or eardrum to readapt to the stimulus not being there that explains how long withdrawal syndromes last for. And we know from research that people who have used long-term antidepressants can show up to 4 years of effects in the brain after stopping, affecting their serotonin system and their hormonal system. I'll bring this to an end. This is basically showing the longer you're on an antidepressant, the more severe withdrawal effects are. So the more common they are and the more severe they are. That's the line below. Short-term studies show minimal effects. Longer-term studies show more effects. These withdrawal effects are often misdiagnosed as someone's condition coming back. I'll skip this. Lots of reasons to stop them. The young lady who left, this is in answer to her question about what long-term studies show. I'll stop it there. Give you some time. Questions. This is how to stop the drugs, a lot of detail, basically going down to very small doses before stopping, much lower than available tablets and capsules makes it easier. And
can I just ask, when you said reducing the dosage?
Yeah.
Just by reducing the dosage, is it enough, or do you actually need to monitor them physically in terms like counseling or IAP that you say to manage them mentally?
Right. So, yes, reducing or stopping the drug can give you withdrawal effects. How do you manage that? You sort of can't put people in hospital because it could take months and years to come off these drugs. You don't need to sort of monitor them. What you need to do is reduce it by small enough amounts that it doesn't cause them huge trouble. So I'll give you the analogy I use is to altitude sickness. Altitude sickness, when you go up a mountain, your body can't handle the huge change in pressure and you get dizzy and you feel sick. The way to avoid altitude sickness is to go up more slowly. And if you start getting altitude sickness, stay where you are, or go back a bit and then go up more slowly. Same coming off drugs. If you do it really quickly, it'll be awful. If you go from the sea level to top of Everest in 2 days, you'll be incredibly sick. If you go from the sea level to top of Everest in 2 years, no problems. Same coming off these drugs. Do it in 4 weeks, you end up in hospital. Do it in 2 years. It gives you much more time to readapt. You start having symptoms, slow things down, go back a step, go down more slowly. That's the kind of that's what I do in my clinic. Just summed up 10 years of work in a few sentences. And it works quite well for people if you do it slowly. Any other questions? Sorry, I hope that's enough.
I think let's give you a round of applause. Yes, and two things I'll just
Please.
say to take the sort of chair's privilege here is Mark's book, which is available at all fine
Sorry, that's
stores.
for doctors. Ignore that. I'm not giving this lecture to psychiatrists. That's not. I'm not.
But you can purchase it on Amazon. I guess it's available at the King's Library as well. Maybe you never know. I wonder, maybe you didn't want to do this, but I'll ask you anyway. Which is, you mentioned in reference to the lady that left, but it could be that this is like 10 minutes slow, I think, or 5 minutes slow. So it could be that she had a meeting at 4. But you mentioned your personal story.
Yes.
So maybe it would be useful to just have a précis of your history in this.
Sure. So I guess my entry into this topic is let me go back here. That website, Surviving Antidepressants, so it was set up by a retired software engineer in America who had real trouble coming off an antidepressant, and all her doctors said it must be in her head. And she basically set up this website, and it's grown. It now gets 750,000 hits a month. And that was the website that taught me how to come off my antidepressant. Now, I trained in psychiatry, did my PhD in how antidepressants work at King's, which is a good university, if you heard of it. And so when I came off my antidepressant after using it for several years, I had all the symptoms that the women at the beginning said: akathisia, panic attacks, that I never had before when I went on them. I went on them because I hated medical school. Medical was horrible, never do medical school. And so I had this very strange experience where the professors I was working with were writing papers saying there's no withdrawal effects from antidepressants, it's brief and mild, no problems, whilst I had huge trouble. And then I found on his websites, first of all, I found a few people saying they had similar trouble. I thought, oh, that's a bit, I'm unlucky, these people are unlucky. Then I found tens of thousands of people on these websites saying something was very different in their experience. That made me, I guess that was the experience that made me reappraise what I'd been taught about these drugs, and realize that a lot of what I've been taught was based on short-term studies, didn't look at long-term outcomes, and that's what's changed the direction of my research, and a lot of these things have come from why I set up the clinic that I run.
Thank you, Mark. So there's been quite a lot of questions from the floor, so I want to give our online attendees an opportunity to ask questions or make comments. So these may be, they've been posting comments throughout the talk, so they might not be necessarily easy to track what they related to. So I'm happy to feed them to you. So let's have a look what we have here. You may have already covered this, so I apologise, Mark, if I missed it. But someone said, now, I think it's more important to know antidepressants themselves can take up to 8 weeks to take effect. Studies should last longer to observe actual effects.
So
do you want to respond to that?
So you can see that's not quite true. You can see here that it takes 8 weeks for a placebo to have a full effect as well. So this idea that it takes several weeks for antidepressant to have effect, if that's true, then all the research that's ever been done, is irrelevant because it's all done on 8-week studies. So you can see effects, you can see, even looking at these things, you can see effects in the first week or two. So that's not quite
accurate. But what interested me the most in all these reviews and meta-analyses, where they testing all of the possible pharmacological strategies on all of the subjects, obviously no, because I might have been in this not significantly more than a placebo group with 6 different psychiatrists that for 5 years have been failing my depression treatment, but up until a doctor prescribed me an ADHD antidepressant that magically worked. So I guess that there's a sort of a synergistic, sort of symbiotic relationship with different types of
I'll take that as a comment.
Yeah. Then I'm just going to rattle through these. So antidepressant drugs definitely need to be matched to an individual. Not everyone is responsive to an SSRI. In addition, other factors can impact the efficacy of the drug. Papakostas, apologies, or Papakostas, found that hopelessness was a predictor for non-responsiveness to fluoxetine. it's so interesting how complex depression is.
So I'll just reply to that. So drug companies often say that you need to keep trying the right drug till you find the right cocktail. There's a meta-analysis of 8 randomized controlled trials that looked at if you don't respond to the first antidepressant, do you respond to a second antidepressant? 8 randomized controlled trials were negative. Meta-analytic result was if you don't respond to the first antidepressant, you're not going to respond to a second antidepressant. So that's not true.
And then the 2 questions that come in, so sorry if I've missed any from online. I'm wondering if there are any benefits to taking antidepressants over taking part in therapy, and also I wonder if there's any info on how long a side effect such as emotional numbing might last. So benefits of antidepressants versus.
So interesting. Therapy versus antidepressants is interesting. So in the short-term studies, they look the same. So they both have an effect size of about 0.3, 2 points on the Hamilton Depression Scale. The longer you go out, the bigger the difference is. So at 12 months, so at 8 weeks, there's no difference. At 12 weeks, there's no difference. At 12 months, therapy is more effective than antidepressants by a clinically important amount. People think the reason is that whatever the drug does wears off over time because drugs have tolerance effects. Whereas therapy is about learning a skill, how to manage your thoughts and emotions and get better at it. So that's why I think there's this divergence between the 2 things. And the second one was, how long does side effects like emotional numbing last?
Yeah,
So that is a huge topic. The answer is we don't know. The answer is some people say it lasts for years after stopping the drugs. So along with, I mentioned PSSD, these sexual problems that can last for years after stopping. One of the main symptoms we'll talk about is emotional numbing. That kind of fits along with animal studies and human studies that show that there are these long-term residual effects after stopping. So the right answer is we don't know. We've never done those studies, but there's signs that it can take a long time to recover. And I guess people are not being told that when they're offered the drugs to start with.
yes, Amelia.
You sort of just mentioned or alluded to like treatment-resistant depression. I recently read this book called The Age of Diagnosis. I don't know if you're familiar with it.
Who wrote it?
Suzanne O'Sullivan. She's like a British
Yes, she's a neurologist.
Basically, her argument, to be very brief, is that like there's a true disease state, and that as part of this pathologization of medicine, like everything has become a spectrum where normal variations in individual difference are being prescribed as depression, or
Yeah.
she also talks about ADHD and autism.
Right.
And so I guess my question is, do you think that there is like a true state of depression, which is what we would call treatment-resistant depression, that is being untreated, or do you think that depression is somehow unique in that it's not like something like schizophrenia, or do you think that everything is really just normal variations in personality?
I mean, I guess I'll say 2 things to that. Number one, that's not how treatment-resistant depression is defined. You're sort of talking about what people would call melancholic or biological depression. Treatment-resistant depression is depression that doesn't respond to the treatment given. It's normally defined as people that don't respond to 2 antidepressants. So, I mean, first of all, the thing to say is, well, that's what antidepressants do. So most people don't respond to them. So a lot of people don't respond to 2 antidepressants. So, you know, so I think treatment-resistant depression itself, you know, is a bit of a marketing term, because what it does is it opens up the market to more serious treatments. But what you're really saying is, you know, you basically say the treatments are not very effective, because in answer to your broader question, you know, is there something out there that's biological, hardcore depression, and everyone else has whatever soft, normal depression? You know, the studies don't find that. Studies don't find that there are people that have uncaused depression. You know, when 70% of us have depression, you know, it's very hard to believe that that's so there's this debate. Do you need an abnormal brain to be depressed? Or do you need a normal brain exposed to certain stresses? And all the research says the second. You know, I can't prove that there's no one out there that has uncaused depression, but mostly they're not found. Some of the stories of people with severe depression in the system sort of hear about abuse, you hear about multiple cycles of drugs after drugs, and then you see people who, you know, don't respond to anything. It's very hard to know, you know, what would have happened if the trauma was dealt with in the first place, rather than a cycle of drugs that have all these negative effects in the long term. So I think, okay, schizophrenia here, but I think depression, you know, we have pathologized what is a normal emotional response to our lives and turn it into a disease, and there's no evidence, you know, there's no biomarkers for it. So either we're not clever enough to find biomarkers, which is what the researchers in this department would think, or, you know, my grandma's right. I'm betting on my grandma.
I don't think there's anything. I'll give the floor another opportunity before going back online. I think Few more questions.
That's fine.
Are you
I'm okay.
Yeah, you're happy
I
to
can
stay.
do it.
Yeah. Super.
Sorry, depression is something that I'm actually quite interested in. There was a study in 2024 by Stephen Holland, What We Got Wrong About Depression and Its Treatment. I'm quite sure you're aware of it, where he actually said basically non-psychotic unipolar depression is actually an adaptation that evolved to facilitate rumination in resolving complex social problems in our ancestral past. That's a normal behavior thing that we have just put a tag that's a disease. It's something. Yeah, so it's quite interesting.
I don't know, Stephen Holm, but that makes sense. People, that's evolutionary psychiatry. This idea that we have adaptations to negative stimuli. That makes a lot of sense. I think they're very sensible. Yeah.
So I'll just go back online, Petra, and then I'll come back to you. So, where is this? Okay. Let me have a look. I'm just trying to. There's loads coming through now, so let me just bear with it. Okay, so wondering if this would be the right platform to ask, but about your experiences with psychedelic assisted therapy versus antidepressants. So I guess.
It's a bit beyond my expertise. I'll
Psilocybin and everything.
I'm not.
They're doing them everywhere. Yeah, but David knows. I would say for more on psychosis and mental health, I would refer you to Robin Murray's talk that he gave for last year's summer school, which sort of touches on a related topic with cannabis and psychosis. Petra, do you want to take?
Sure.
So I kind of have two, but one is around resilience, and you kind of already alluded to this with therapy, how you're like learning coping mechanisms and things like that. And I was wondering if you've read studies around this on, like, I don't know if these exist. I haven't looked into this recently, on sort of a baseline resilience, I suppose, and where antidepressants might help to even be open to learning, for example, coping mechanisms. Because another, like, for example, even with like alternative therapies like yoga, there are lots of studies on that trying to prove that that works best because everyone's looking for a silver bullet. But then, like, my argument on, I'm a part-time yoga teacher as well, but it's like, if you're like, if your state is that you can't even brush your teeth, like, how are you going to go to yoga, sort of thing? Like, just like these sort of questions. So the resilience would be my first question. And then second question is, you mentioned neurogenesis, and I know that on our masters we've been learning about how, for example, if you are on chemotherapy because of cancer, like other drugs basically that are stopping neurogenesis, and then people would be depressed after recovery as an effect of the drug. So have you seen examples where essentially antidepressant is almost used like probiotics for antibiotics, like kind of like, because something's been induced by another drug?
Yeah. So, what can I say? So, I mean, resilience, yes, obviously it's I guess it's the opposite of neurosis. If neurosis is sensitivity to stress, resilience is resistance to stress. So, of course, it's a good thing. Do I think that antidepressants helps people to learn new things, or to do things that are like yoga? And that is often given as a reason. It's a bridge to therapy is kind of one of the talking points from drug companies. We did a study where we looked at people in talking therapies, IAPs, in the NHS, and we found that people who are on antidepressants have a worse response to therapy than people who are not on antidepressants. And we hypothesized that a drug that interrupts your sleep, that makes you foggier, that makes it harder to think straight, cannot help you in learning new skills. I kind of take your point that if you're lying on the ground, you can't get out of bed, having a drug that numbs you might be useful to get you to yoga class. There isn't research that shows that very clearly, but I guess it's plausible. I'd be thinking if that's the case, that you should use for a very short period of time because all these things kick in. And the second question was neurogenesis. I mean,
for example,
yeah.
and then after effects.
Yeah. I mean, I'm guessing, I don't know, not my area exactly what you're talking about, but I'm guessing that after you stop the chemo, there's probably a surge in neurogenesis because you sort of knock things down and there's a kind of repair mechanism that happens.
So they've seen that once you've recovered and stopped chemotherapy, because like it was kind of like delayed, and that's why people were like, why am I depressed?
I've recovered from cancer, and the research on this was showing that it's because this is kind of delayed the neurogenesis.
Right.
Like you would be maybe starts generating, but like until you kind of get back, I guess, to that level.
I'm a bit. I guess I'd be a bit skeptical that there's lots of reasons why people would be depressed who have cancer and are getting chemotherapy. To sort of hone in on it's the neurogenesis as the cause, I'd be a bit skeptical. There's lots of chemotherapy affects your entire body. You feel terrible.
Yeah.
To say that there's a correlation between neurogenesis and chemotherapy and depression, therefore it's neurogenesis, I'd be a bit skeptical of that. And the idea of giving an antidepressant that probably causes maybe more toxic effects to the brain as a way to counteract chemotherapy sounds implausible to me, but I don't know the research.
I'll take a question online because it gives me an opportunity to sort of broaden it out to areas that we don't know much about. So this question is fascinating talk. Thanks. I wonder if there's a connection with late diagnosis of autism in women and emotional numbing from antidepressants. And I guess I would hijack that question and also ask.
Yeah.
And I think you mentioned this in the talk, but I believe there's the question marks about the vestibular system and maybe falling over in older age, and maybe antidepressants having some role to play there. So
I guess I can't speak specifically to females in autism and antidepressants. That's a very specific subgroup, but I can say in general that the side effects of antidepressants are often missing in doctors' differential diagnoses. So, for example, antidepressants are known to cause concentration and memory problems. It's on the drug company leaflet for each drug. And so I can't help but think that a lot of people who are diagnosed with ADHD who are on an antidepressant might try stopping the antidepressant to see if that's causing it. Antidepressants cause all sorts of sexual numbing. There's a whole lot of people with asexuality these days. And so I think the same thing about autism. If your ability to if emotional numbing affects your interpersonal social cue taking, then maybe it could be misdiagnosed as autism. So I do think that the profound social, cognitive, emotional effects of antidepressants are missing in the conversation about what's causing the rise of all these diagnoses.
very good. Yeah, I think we're really making the most of your time here. So
if you want to say 5 minutes, I can do it. But if you want to end,
yeah, no, I'm sort of
I can do
taking
5.
cues from you.
I can do it. I can do it.
Firstly, just thank you. And secondly, what's your opinion currently on novel treatments such as ketamine or major depression?
So I think we've gone from using drugs that are a bit like street drugs to using drugs that are street drugs. So antidepressants,
I mean,
yeah.
I hear that.
Yeah.
But was ketamine not originally an anesthetic?
Yeah. So it's an anesthetic because the reason why it's an anesthetic is it shuts down your brain, but it doesn't shut down your cardiorespiratory system. So that's why it's used, in emergency situations. So it's one of its key properties. Can ketamine make you feel good? I think ketamine can make you feel good, as can, cocaine, heroin, and alcohol. Is ketamine good for you? Is it useful for depression in the long term? It's a very different story. Long-term ketamine users generally are depressed, have impaired memories, have their bladders stick together. They get ketamine bladder. In animal studies, animals given ketamine showed brain shrinkage over time because it's got a neurodegenerative effect in the brain. So the studies that ketamine, I mentioned at the beginning, the studies that ketamine have become popular from are 3-day, 1 week, and 4-week studies that show an improvement in some depression scores. People say that ketamine can give them a transformative experience sometimes. I think that's probably true, as can yoga or dancing or trekking in the woods. So I'm sure that's the people that benefit from it. But do I think it's a safe and effective treatment for depression from long-term studies? There are none. S-ketamine, Spravato, is a drug that Janssen tried to get approved in the UK. It failed, according to NICE, because it didn't show clinically important differences at 4 weeks. It increased the suicide rate in the group given the S-ketamine compared to placebo groups, and there were long-term safety issues to do with bladder and worsening mood. So I think, I guess, talk about depression as being caused by people's lives being overwhelming, the stresses, their emotional needs not being met. I think ketamine fits into that drug-centered model I talked about, that some people could get a bit high, dissociated. It's in the nightclub it's called off your face, which might give them relief from their symptoms. But as a long-term treatment, I think it's very fraught with dangers.
Do you think it has any utility as a short-term mechanism, maybe in a similar way to
It's my concerns with that are that short-term treatment inevitably turns into long-term treatment because people like things. It's hard to stop because of withdrawal effects. So I'll tell you what I think is a very good model for using psychiatric drugs. If you go ask a doctor for a benzodiazepine, Valium or Xanax, not Xanax in this country, Valium, doctor will say to you, this drug is bad for you. If you use it too long, you'll get addicted to it. You'll get dependent on it. It'll be hard to stop. Use it as little as possible. If you want to use it to go fly to America, okay. I think that's a very good model for things. You're being told that there are dangers to long-term use. Use it as little as possible. But if you're really in a spot, you might use it. I think that's a very sensible way to use most psychiatric drugs. And maybe ketamine, although, of course, who's the guy from Friends who died in his hot tub? And there's all sorts of issues that come up with.
I'll use that as a jumping off point because let me try and play devil's advocate or just try and introduce a bit of the alternative view. And please do push back on Mark. He's very open. So I guess what one would be forgiven for thinking this is almost borderline anti-psychiatry, anti-psychopharmacology, and
I've got a PhD in psychopharmacology.
Yeah. So I guess because you've sort of truncated your talk for time,
yes,
you didn't have the opportunity to really spell out deprescribing. So I guess my question is hopefully going to sort of motivate you to sort of go through that. But also another thing, which is, let's say you have somebody, what you're not sort of, well, what are you saying? Are you saying that we shouldn't prescribe antidepressants? What would be your advice to clinicians when they have somebody coming into their clinic and they know that antidepressants work in their experience? Are they going to look at the Horowitz school and go, no, you need to go through rather a lengthy waiting list to get therapy? So there's an empirical point here, definitely. And conversation that's very academic, but there's also the reality of most people. So
So maybe very good question, Dr. Westwood. I'll skip the deprescribing stuff because it's a bit technical and we're out of time. So let me talk about the practical things. What I think a clinician, because maybe I sound academic here, but I see patients. So I work in the NHS. I see psychiatry patients. Maybe I'll talk about what I think informed consent looks like if you're thinking about using an antidepressant. So I think, is there a role for antidepressants? I think there should be much less of a role for antidepressants, but probably clear from my talk. I would say informed consent, because that's the thing. Doctors don't tell patients what to do anymore. That's sort of old school paternalistic medicine. Informed consent means you let people know what the facts are and let them make a decision. There's 5 things that someone needs to know about antidepressants to take them: how effective they are, what the side effects are, what stopping them looks like, how they work, and what the alternatives are. I'll give you my 4-minute spiel. So the drugs, are 2 points better than placebo on a 52-point scale. So most people will not experience a significant difference. That's what 1,000 studies show. That's not my opinion. That's what meta-analyses show. Side effects, I've mentioned a lot of them. Gut side effects, problems with sleeping. Sexual side effects happen to 50% of people. Some people between, maybe as little as 1 in 200 will never get their sexual function back after stopping. Emotional numbing, blah, blah, blah. I've mentioned a lot of those. Number 3, we don't know how the drugs work. We think the most likely explanation is that they cause emotional numbing. And some people find that helpful in the short term, especially if they're in terrible straits, but that might have consequences in the long term. What are the alternatives? According to the NICE guidelines, which the government department puts out guidelines, there are 19 equally effective and cost-effective treatments for depression, including severe depression. I don't know if I've got a slide on them. They include therapy of various forms, cognitive behavioral therapy, psychodynamic therapy, exercise, mindfulness. The number 1 most cost-effective treatment for severe depression, according to NICE, is problem-solving therapy. Problem-solving therapy is where you go see a doctor or a counsellor. You write down the top 3 problems in your life. and the first step to take for each one, and report back with progress made or barriers encountered in 2 weeks, which I think really gets to the heart of is the problems in your lives that cause depression. So those are the 19 things. It's a slightly separate question as to resources availability. I think that one of the things we should be advocating for is to have more of these things available, and also to price things properly, because, as I've said before to the question, that the long-term effects of the drugs are not coming to it. And what does stopping look like? The longer you use an antidepressant, the harder it is to stop. Some people find it so hard to stop they're unable to do so, or doing so causes akathisia, suicidality, can lead you to hospital, and it can cause months or years of disability. If people want to take a drug after that, then that's fine, but they should know those things. People might quibble about, I guess the bits where people might quibble, I'll play my own devil's advocate. Some people will say there's a small proportion of people that will have more than a 2-point difference. Some of them will have, a 5-point difference. Some will have a 0-point difference. One of the problems is we don't know who those people are that have the 5-point difference. And the 5-point difference is still only after 8 weeks. What else people quibble with? People might say there's sexual problems. Maybe it's 1 in 200. That's pretty rare. I agree. If it's 1 in 7, that's pretty common. Some people might say, no, we know the drugs work by decreasing inflammation. That's very questionable. No one's proven that it's emotional numbing. It just happens that emotional numbing happens to 3/4 of people, and of course that decreases your scores on these depression scales. So I'm sure that these things could be open to criticism. That's what I say to patients when I see them. That's what I guess there is a range of psychiatrists, my colleagues say similar sort of things, but I'm sure there are people out there saying they work like insulin for diabetes, they work great for lots of people, easy to stop. I think that the evidence doesn't back up a lot of those assertions.
I think we'll end on that note. Mark, thank you so much. Another round of applause. I think I speak to everyone that we could have a lock-in with you, Mark, and just keep going and keep probing. So, boys and girls, this is it. This is the end of the road. Now it's over to you. You are now official troublemakers. So you can go out into the wild now and try and practice what we've been preaching. So best of luck. And may the odds be ever in your favour. Do feel free to email me. I will, over the next few weeks, probably not while I'm in Ireland next week, because I'll be drinking a bit of amber nectar, but I will be uploading the videos from all of the week to our YouTube channel, and I'll circulate that through the mailing list that you will be part of if you registered in Eventbrite. If you didn't, just email me. You'll find my email, or you can just search for me on Google. But thank you all so much for coming. It's been a wonderful pleasure to see everybody's faces new and repeated. So until next year, see you later.